It's a very long title. I have a talk I give on fibromyalgia. It's quite long. I have 30 minutes to do what I normally could probably do in a half a day. So we're going to just get started. But I direct the Fibromyalgia and Centralized Pain Research Lab, also known as the FACE Lab. We try and put faces to invisible illnesses, and that's my life's work. So we're going to just go off and start with our objectives about what is fibromyalgia. I know everyone here, probably who has fibromyalgia here? Who is a loved one or a supporter of a person with fibromyalgia? Any clinicians in the audience? Fantastic. All right, wonderful. Well, we're going to do a quick overview of what fibromyalgia is. What do we know? What are the risk factors? How do we diagnose it? What are the mechanisms that lead to how a person develops fibromyalgia, which I've been discussing with some colleagues today. That is very multifactorial. It's I was likening it to a plate of spaghetti noodles. And this is how I describe it to my patients, because patients start with fibro when they're young or when they're older. It can happen as a result of injury or as a result of viral illness. And that pathway on a plate of noodles, it's like you're trying to find that pathway from start to finish for that patient. And it's why the patient story is so important. And I spend most of my time with my patients getting to know how their journey started and how they got to the point where they are today. And it's very different for everybody, but it's important to notice these things because we do see themes, and that's how we can work on developing research to make things better, to understand all those different phenotypes that exist within the fibromyalgia spectrum. So what is fibromyalgia? This is just kind of our Fibro 101 slide. It is a chronic pain syndrome that is essentially associated with widespread body pain, but there's a lot of other associated symptoms that patients with fibromyalgia experience. And this is not an exhaustive list, but it's part of the diagnostic criteria. So you can see mood alterations, things like anxiety, depression, sleep disruption is very, very common. So this is not only harbored by a difficulty in falling asleep, but difficulty maintaining sleep. And then if you do get restful nights of sleep, oftentimes you wake up and you're like, I'm not refreshed. And then you spend the whole day being tired. So it's a cycle of sleepiness, fatigue, and then cognitive difficulties. Who here experiences fibro fog? Right? I know I do. I felt it when I had a newborn, but I know with my discussions with my fibromyalgia patients that that is an all-day, everyday thing that can vary depending on levels of sleep, sickness, stress, all different types of things can go into why you have those cognitive issues. So when we talk about the impact of this disorder, it's so prevalent. And this is what I always talk about with my patients, because they're like, Doc, I don't feel like I'm part of this world. I feel like I'm different. That I'm an outsider. 2 to 8% of the population has this. And honestly, I believe it to be higher because it's a spectrum diagnosis. So not everybody is meeting criteria fully at all times, but we all exist on the fibro spectrum. I'm a little bit fibro myself. If I get an illness or I get sick or tired, I have headaches, I get tenderness, and I feel pain and fatigue. And so it's important to recognize that this is extremely common. It's just that a lot of times it's underdiagnosed for a variety of reasons, which we'll talk about later. Interestingly, patients with fibromyalgia, so these are like little bits of history I ask about when I'm seeing patients. Oftentimes pain starts when there's in either early adulthood or sometimes even in adolescence, but it doesn't generally manifest as fibromyalgia super early in all individuals. Now, there are some individuals who have an early onset of fibromyalgia. I know Orla developed it when she was quite young, but oftentimes we see the development of other types of pain syndromes, whether it be migraines, abdominal pain, endometriosis type pain, TMJ, earlier in life. And that those are more regional centralized pain syndromes. And then there's kind of like a coalescing to fibromyalgia, which is that widespread centralized pain syndrome. And like I said, adolescents, young adult, but I do see patients who kind of go through most of their life, but maybe perimenopausally is when they started developing the symptoms. So there's no rhyme or reason. Like I said, the spaghetti plate is full of different noodles when it comes to fibromyalgia, and it's our job as clinicians to help speak with patients and understand the path that that noodle is taken to get to the diagnosis of fibromyalgia. So what are different risk factors? Can I pull this off and walk around? I get a little antsy. I just need to move. So what are the different risk factors? So we do know that there is a genetic predisposition. So that's why I put the picture of the DNA there, because we do see that there is about a 50% when they've done studies of identical twins. We understand that this is about 50% genetic and about 50% environmental. So that genetic predisposition, if you have a first-degree family member with fibromyalgia, you yourself are 8 times more likely to develop the condition later in life. When you look at the other risk factors, we know that this is more of a female predominant disorder. If you look at all the studies, there's a variety of ranges of ratios, but generally speaking, it's about 4 to 1 female to male. As I said earlier, it can develop at any age. So I've seen patients as young as 14 who remember developing pain when they were about 10 or 11. Within my hometown of Kansas City, we have a children's hospital, and they run an amplified musculoskeletal pain clinic to try and have early intervention in those children who have chronic migraines, chronic abdominal pain, knowing that that potential for fibromyalgia is there. And with that earlier intervention, they're hoping to try and kind of change some of those neuroplastic, centralized pain issues that are going on to make their outcomes better later in life. And that's part of where I think research really needs to go, is how do we identify early so that we're not catching people when they've already gotten to the point of severe widespread fibromyalgia, to see if that early intervention makes a big impact. Does anybody here have autoimmune disorders? Yes, so we know that patients with autoimmune conditions or rheumatism, lupus, Sjogren's syndrome, there's a whole variety of autoimmune conditions, that there's a 10 to 30% chance in just an autoimmune condition of developing fibromyalgia, which we deem as secondary fibromyalgia, meaning it's due to that underlying autoimmune condition. But by no means are they mutually exclusive. You can have both at the same time. Okay, additional risk factors. So stress. We know that if you've had a history of trauma, you've had a life of stress, and this can come in a variety of different ways, right? Like you can have a chaotic home environment. I hear a lot of stories. Like I said, I really like to get everybody's pathway, everybody's journey, so that I can understand and kind of paint a picture of how this developed. We know that having that kind of early life stress or even early adulthood stress can be linked to this. I have a patient who developed it after a really difficult divorce where there was a contentious custody situation. Later, we found out that her mother and her grandmother had fibromyalgia. So we were kind of talking about this just at the pub yesterday, which is exactly where you should discuss science, right? When in Ireland. But essentially, I believe there's like a genetic priming, as we discussed. And some people maybe don't even know that their family members have fibromyalgia. Maybe they were never diagnosed with fibromyalgia. They just, that was Granny with the chronic pain, right? Like Granny was tired. She was, had a lot of pain, but no one ever diagnosed her. But you kind of get these family histories when you're talking to patients, and then you hear about this traumatic event. And I'm like, oh, they were genetically primed. But maybe they hadn't had a lot of stress until that moment. But then you add the stress on top of the genetics, and there you go. And so for the clinicians in the audience, I encourage you, as you're speaking with your patients, to really understand those life stories. I usually tell them to start in childhood, tell me how that was up until now, and you'll get all the little pieces that can kind of put the puzzle together for you. I also see this, we were just talking over here with Rachel about different types of infections. Lyme disease has been associated with it, and what we're understanding more and more about in our post-COVID world is that long COVID shares a lot of commonalities with fibromyalgia. And within my country, I had a chance to speak with our Assistant Secretary for Health, and they're going to be putting a lot of money towards studying long COVID, which in my opinion means we're going to be studying fibromyalgia, which with much more money in the United States, which is great, but it's sad that it's under the premise of long COVID. All right, so who here got their diagnosis of fibromyalgia by being touched on tender points? Okay. Who here in the audience can touch here who doesn't have fibromyalgia, like on your trapezius? It hurts, right? Like you don't have to touch that hard. Most people have tenderness in that trigger point. So this is how we used to diagnose fibromyalgia. This is the 1990 American College of Rheumatology diagnostic criteria. So if you had tenderness and greater than or equal to 11 of these 18 tender points, again, in generally commonly tender points. So over your elbow bone, like that doesn't feel great to push. Over your knee bones, I mean, it's a lot of prominences that aren't generally not tender anyways. What we found is that this over-diagnosed females and underdiagnosed males, because, and if I had a whole other talk, we could talk about how men and males have decreased sensitivity to touch. And we can use all different types of machines to elucidate this. But females are just generally a little bit more sensitive to any type of stimuli. So what happened is we came up with this new way of diagnosing fibromyalgia. So the criteria that came out in 2011 were then revised in 2016, have thrown out the tender point exam, and it solely relies on a self-report survey that consists of patients checking boxes, and we'll go over this in just a second, but understanding that this is not a yes or no disorder, that it is a spectrum of pain, hyperalgesia, which means increased pain to painful stimuli, allodynia, which is our term for pain to non-painful stimuli, and that needle, that kind of continuum changes for patients. And so one day you may be more extra sensitive. Maybe there's a bit of bad weather coming through and you kind of feel just extra sensitive. And then there might be days where you're having a good day, right? So that fact that changes from day to day means this is a very dynamic disorder, and it is not just a you have it or you don't. I firmly believe it is like we all exist on this spectrum, and it's because our brains, this is a true brain pain disorder, and so our brains have this innate ability to change how we function, how our brain functions in terms of pain processing. So what we know now is that the pathophysiology of this, which is our fancy word for how it happens, why this happens is that the central nervous system becomes revved up and it changes how it processes pain. It basically feels pain when you shouldn't have pain, just like as if who here with fibromyalgia, sometimes you can't even have someone like lightly shake your hand, right? Shouldn't hurt. Right? That's not a noxious stimuli. Someone's not coming at you with pokers, right? But it hurts. And it's because you have that increased sensitivity, and that's your brain sending increased blood flow to pain areas of the brain and decreasing blood flow to areas of the brain that can limit pain. So it's an amplified system, and the treatments are aimed at those systems. And we have a slide here in a little bit talking about the different mechanisms. By the way, I give the same talk that I do for doctors as I do for patients always, just because I think it's important for everyone to see this as what it is. It's a very real disorder for patients, and it's a very real disorder for physicians who are treating it. So, as Orla said, I don't just treat fibromyalgia. I am generally the fibromyalgia doctor for pretty much most of my region. But we see other syndromes that correlate and that coexist with fibromyalgia. And for the clinicians in the audience, if you see these diagnoses on the chart and a patient comes to you with widespread pain or other associated symptoms, it might put a little light bulb in your head to think, gee, if this patient has migraine, temporomandibular disorder or TMJ, irritable bowel, interstitial cystitis. These are all of the different chronic overlapping pain conditions that are known to have that same central sensitization or central pain amplification that we see in fibromyalgia. We even know that chronic low back pain, so patients who have chronic low back pain, maybe they've got some degenerated discs on an x-ray, but their pain is very severe for basically when you correlate it to the imaging, that chronic low back pain in and of itself has been shown to have levels of central sensitization. Okay, so it's cutting off a little bit on the right, but that's okay. So how do we diagnose it? So you remember I talked to you about the self-report survey. So I give this survey to anyone who walks in my office. I don't care if they have fibromyalgia or not. Because it gives us great amounts of information. So this takes about 2 minutes to complete. For the clinicians in the audience, this is readily available online. It's free. If you come up to me later and give me your email address, I can send it to you in PDF format. Very easy to score. And what it does is it gives you a score from 0 to 31. That basically gives you your fibromyalgia-ness. It's a real medical term. We use it in our literature. I know it's really silly, but it actually really perfectly explains how fibro you are. So obviously, a score of 13 is what it takes to meet the criteria for having fibromyalgia. But think about it. If a person has a score of 13, compared to a patient with a score of 31, they both meet criteria for fibromyalgia, but they both have very different symptomatology, I guarantee it, because a person with a higher level of widespread pain, a higher level of symptom severity index, as you can see at the top, the participant who's taking this survey would rate their fatigue, their trouble thinking, whether or not they wake up unrefreshed, and they rate it as mild, moderate, severe. So your max score on this is a 31, and for me, when I see a patient with 31, I know that their symptom burden is huge. That this is someone who's probably having a really hard time functioning in their daily lives. Maybe they're having even trouble taking care of themselves, doing their activities of daily living. Whereas a patient with a score of 13, depending on where they get their points, maybe they don't have really significant widespread pain, but they've got a lot of these other associated symptoms that we know go along with fibromyalgia. So what this score does for the clinicians in the audience and for the patients is it lets me know where your barometer is, where that needle's falling on how bad your symptoms are for fibromyalgia. And in our research, where we're using, I use this survey in all of my research studies, we know that the level, that score, corresponds to outcomes from a variety of different treatments. And so the goal is to try and reduce the symptom burden by bringing that score down. Okay, so fibromyalgia, and at least when I was training, so I was trained in interventional pain medicine. So I'm like the guy, I'm the girl with all the guys. Only 15% of pain doctors are female who are doing epidurals, nerve blocks, injections, spinal cord stimulators. I was taught to do all of this stuff. And fibromyalgia was a feared diagnosis in our clinic. All of my other providers would say, oh gosh, here comes the patient with fibromyalgia. I'm like, why are you saying it like that? Do we need to whisper about fibromyalgia? The fact of the matter is, and this is why I bring up the idea of chronic low back pain, is that we know that fibromyalgia is actually just the tip of the iceberg. When you dig deep into the pathophysiology of all chronic pain conditions, there is a level of centralization or that central pain amplification that's occurring in pretty much all of them. And so fibromyalgia, I hate the term because I don't think it accurately describes what patients experience. It's really just a widespread chronic pain. I like to call it like a widespread central pain amplification syndrome, but I can't come up with a good acronym. There's POTS, there's PANDAS, but I can't come up with a good one. So we'll stick with fibromyalgia, but recognize, again, it's that spectrum, that idea that the level of centralized pain corresponds to the degree of symptom burden and the amount of pain we're having at any given time. And I think, and this is a slide that I really like to talk to my patients about, is, and so when I'm talking to you as a human and not as a doctor. When people see you, they look at you and they don't understand how you can be in so much pain, right? I mean, if we see someone on the street with crutches or with oxygen, like you look at that person, you're like, they're ill, right? Because you can see it. But with fibromyalgia, you can't see it. And generally speaking, most patients who come into my office do not look ill, but they are. And so it's a really sad state of affairs when I'm learning how to be a pain doctor and my colleagues who are trained board certified doctors are telling me to fear a group of patients because they're difficult or complex, when really the mechanisms, the pathophysiology is what is complex, and we need more research to make things better for patients. So what do we know? This is, okay, if I like I said, this could be like a day-long talk where I could go through all the science, but I'm going to get to some of the treatments so we can go over how best to take care of fibromyalgia patients. But what we know, again, it's that amplification of sensory processing. And we use specialized quantitative sensory testing to elicit pain thresholds, understand, if I put this little pokey thing on a patient, what pain score are they going to give me? Or if I have these little machines that squeeze thumbnails, it's really mean. But we're able to, I know I've done it myself, and I was like worse than childbirth. I'm like, that's a 10 out of 10. But what we're able to do is identify the amount of pressure that will then change from feeling touch to pain. And so by using these, fancy equipment things, we're able to identify how sensitive a person is to pain. And we know that patients with centralized pain, such as fibromyalgia, but again, across the spectrum, migraine, chronic abdominal pain, interstitial cystitis, endometriosis, all of these patients who have done these tests as a part of research studies for centralized pain, we know that they have decreased pain thresholds and that they have increased amplification to prolonged stimulus. Some of my good colleagues at the University of Michigan have done some really amazing work where they actually use the thumb squeezer while the patient's in the MRI scanner. And what we know, when you put a painful stimulus on a patient with fibro compared to a healthy control, and then we scan their brains to see the changes in blood flow, we're actually able to see a fibromyalgia brain, because what we know compared to the healthy controls is that patients with fibromyalgia, we can watch their blood flow change, and it goes to what we call the pro-nociceptive or pro-pain areas of the brain, and there's a decreased connection to the areas of the brain that are like, hey, there's pain, turn it off, turn it off. And so we do have these mechanisms within our brain to kind of dampen pain, but in patients with fibromyalgia, that's impaired. So there is a true neural correlate for the pain that patients with fibromyalgia and complex centralized pain patients have, where we're able to see it. So it's not fake, it's not made up, it's not in your head, it's just in your brain. That's all you have to tell people. All right, so we're gonna go over a quick treatment. I know I only have like 10 minutes left. I believe in integrated medicine and multidisciplinary approaches. In the United States, we like to give drugs to lots of people. That's why we have an opioid epidemic. When I trained early in my career, it was like, you want fentanyl patches, oxycodone? Like, unfortunately, the pendulum has swung way too far the other way, and now legitimate chronic pain patients can't get good treatment. But that's a whole other separate story for the pub later. But that idea of pharmacologic, knowing that we have these mechanisms, these changes in brain connectivity, neurochemical changes, that we do have good drugs to treat those, but that's not the whole case. You have to do these other things such as mindfulness, meditation, exercise, in whatever form that looks like for you, to be able to kind of hit all those different pathways through different treatment mechanisms. I also think, and this is something at least in, knowing Orla and what she does to take good care of herself, she's an amazing runner. I mean, yes, you are. Don't you shake your head. But I have found that most of the patients that do really well with treatment are the ones who are motivated and enthusiastic about their progress and about getting better, knowing it might be difficult. But I tend to work as like their cheerleader when I'm treating them. I'm always like, think of me in the background doing jumping jacks for you. Like, I'm really proud of you. Even if today is just your day to get up and shower, Dr. Chadwick is proud of you that you did that today. So having that good, positive, hopeful attitude has been shown in research to make for better outcomes for patients. Typically, fibromyalgia, at least generally speaking, can be diagnosed and treated in the primary care setting. I think you guys call those general practitioners here. In the States, oftentimes the general practitioners are just too busy worrying about diabetes and high blood pressure, and so they usually send all the patients to the pain doctors to get treatment. The pain doctors only want to do injections, or that's really it. And so then they kind of end up in clinics like mine, who are historically trained interventionalists who just dabble. and have now made it their entire life to treat this condition. So comprehensive pain doctors can help if your primary care provider or your GP is stuck in terms of treatment. So what I'm going to do now is just go over, I'm going to skip this slide just for time's sake, but when I'm seeing patients, I try to recognize which bucket of pain the patient is experiencing. So we'll just go over this real quick. So nociceptive pain is pain that is due to inflammation or damage, and it's very well localized. So a patient with knee osteoarthritis of the medial compartment will point to the medial aspect of their knee. The pain will be consistent with activity, and we might diagnose them with osteoarthritis. They might go see a surgeon, have some injections. Maybe they get their knee replaced. But ultimately speaking, the treatment for that peripheral pain is either NSAIDs, injections, surgery, and they're well treated by that. Neuropathic pain is a little bit different. Does anybody here have carpal tunnel syndrome? So carpal tunnel is a neuropathic pain condition. We know that it's caused by compression of the median nerve. Sometimes you can do physiotherapy, you can wear little splints to decompress the nerve. Sometimes you end up having surgery, but generally speaking, that peripheral condition is treated very well by things to address the nerve issue. Now, centralized pain has recently been changed to nociplastic pain by the International Association for the Study of Pain. As we said, it's different. It's not a peripheral problem. This is a central nervous system problem. So the typical treatments aimed at treating peripheral issues don't tend to work very well for fibromyalgia or centralized pain. So we're looking at different types of therapies like central nervous system acting drugs and then non-pharmacologic therapies, which we'll talk about in just a second. So this is, I'm gonna have to look at who put all this animation. So this is a very busy slide, but I hope this helps you understand just how complex fibromyalgia is. It's not like diabetes type 1, where we have an autoimmune disorder that makes the pancreas not make insulin. Like that's just cut and dry, right? All these things are changing to facilitate pain and inhibit pain transmission, and decrease inhibition of pain transmission. So what we know based on fMRI studies, other types of studies of the brain, is that glutamate, which is an excitatory or pro-pain neurotransmitter, those levels are increased. Ways to decrease them, which would help pain, would be things like gabapentin, pregabalin, also known as Lyrica, ketamine, memantine are all things that can be tried to reduce our glutamate levels. But remember, that's just one mechanism that we've seen in fibromyalgia. So other types of treatments aimed at serotonin are things like triptans. Does anybody take those types of drugs for migraines? Yep. Cyclopentazepine, which we call Flexeril in the United States, it's a muscle relaxant, but that can actually work well on serotonin levels. So people think, oh, it's just a muscle relaxer, but it actually works on some neurotransmitters to help basically decrease that pain transmission. And then here on the right side are descending anti-nociceptive pathways, which basically means top-down pain inhibition can be helped by these different drugs here. So we've got tricyclic antidepressants. Those are things like amitriptyline, nortriptyline, doxepin, desipramine. They're very old drugs and they have lots of side effects, but for some people in small doses, they can work. We know that patients with fibromyalgia have increased levels of circulating opioids that their body naturally makes. So those are your endorphins, your body's endorphin system. It's sad because everybody's like, oh, go get your run on for your endorphins. Well, patients with fibromyalgia already have a lot of excess opioids. And what happens is that dysregulates the opioid receptor system. And so a drug called low-dose naltrexone, which I'm actually going to talk in a couple slides about, can target that opioid system and bring balance to it again. Cannabinoids, I talked to someone earlier today who said that they are not legal here. We in America just like to be weird because we're like 50 countries in one country, and then all of our states have their own laws that they can pass that are different than the federal laws. So I'm in Kansas, which is right next to Missouri. So Kansas, we actually cannot have medical marijuana, but Missouri can. And like literally it's, you go on the internet, you like type in this thing and you meet with this doctor and he's like, do you have pain? And then he's like, here's your card. I mean, that's how easy it is. And then if you're in California or Colorado, you can just go like McDonald's, like, hey, I'm just going to walk into the store. That looks good. Got my marijuana. Time to see if it'll help my pain. I know it's not like that here, but there is some evidence that cannabinoids, so cannabinoids is part of the marijuana plant that does not cause the euphoria that the THC does. What we know about the CBD or cannabinoid portion of the plant is that that is actually our pain treating molecule. And so for when I'm giving this talk to patients in the US, it's you want a high CBD to low THC ratio so that you're getting more of the pain fighting agent compared to the thing that makes you feel a little bit funky. All right, so this is just overview of the evidence. We've got strong evidence for the tricyclics, the other types of antidepressants such as milnacipran and duloxetine, modest evidence for tramadol, which is a weak mu opioid agonist. So it is a very weak opiate, but it also works on our serotonergic system. So I like tramadol for my patients who need that for that kind of as-needed pain relief because it has that dual mechanism of action as an antidepressant as well. GHB, I wouldn't recommend giving that to people. Does anybody know what GHB is colloquially? In America, they call it the date rape drug. Yeah. Can you imagine doctors being like, yeah, go take that? So don't give that one. But low-dose naltrexone has modest evidence. Cannabinoids has really good evidence as well, modest evidence. There's no evidence for opioids, corticosteroids, non-steroidal anti-inflammatory drugs. But remember, there's 3 buckets of pain. You can have your nosoplastic pain or your centralized pain due to fibromyalgia, but just because you have fibromyalgia doesn't mean you don't have osteoarthritis or something else going on that you might benefit from taking those medications. So when you look at this slide, it's really meant to be for fibromyalgia, okay, nothing else. Okay, so I know I spoke a little bit about low-dose naltrexone. This is something I've been using a lot in my practice. Naltrexone historically is a opioid antagonist. So if you think about naloxone or other things to reverse opioids, this is the same type of drug. But what we do is we give it in teeny tiny doses, like microdosing. And when you look at the research, not only does it help restore balance to that opioid system, but it also works as a potent neuroinflammation reducer. So there's a little pathway in your spinal cord and in your brain that is modulated by glial cells. And those glia cells their only job is to spit out inflammation into your body, right? And so by blocking that pathway that activates them, you're reducing inflammation, but it's not like your typical NSAID, such as a ibuprofen or meloxicam. This works in a different way, so you don't get all those bad side effects that NSAIDs can give, like stomach upset and things like that. The only downside is in the States, we cannot get this without having it be compounded by specialty pharmacists. So you have to use like a pharmacy where they can take the 50 milligram pills, which is what's commercially available, and then they grind it down and they make it into smaller pills because we dose this anywhere between 0.5 to 9 milligrams. But what I've found in patients is it can be really helpful and it causes minimal side effects. The only downside for us in the States, because we have to pay for lots of things in our healthcare system, is that it's not covered by their insurance. But I've been lucky enough to find some pharmacies who can make this for 3-month supplies for about $50 in the US, which is not horribly expensive in the long run. And the types of side effects are really, really small. And when you look at the literature, not only has it been shown to be helpful for fibromyalgia, but it's been shown to be helpful for CRPS, which is also known as reflex sympathetic dystrophy, multiple sclerosis, neurogenic itch, burning mouth syndrome, and then chronic fatigue syndrome. So this medication has been shown not only to help pain, but fatigue as well. So I don't know if this is available here in Ireland. It is. It's a really great option. It doesn't work for everybody, and there are potential for side effects, but overall, I have found that it can be helpful. And just, this is a slide for the clinicians in the audience. It's typically how I dose this. I start at a very low dose, and then I up-titrate. Start at 1.5, usually about 2 weeks, and then they can go up. Sometimes I'll even have it compounded into a liquid so that it can be titrated even slower for patients who are sensitive to medication side effects. Now, Orla, can we make these slides available for the people? Okay, just so that you're not like, oh my God, am I gonna get a picture? Okay, this is an overview of non-pharmacologic therapies. Education, I think, is so important. How many of you, when you got your diagnosis, do you feel like the person who diagnosed you gave you education like this? Yeah. So education is so important because knowledge is power. And if you can understand what's happening in your brain and your body and why the medications are used, I mean, I feel like it's empowering, right? And I have had patients tell me like, oh, I think I understand my condition now. I've had it for 10 years and no one's really explained it to me. Like, I guess I get it now. I am a very big proponent of physiotherapy. I know Dr. Giuliani is as well. It's a really great modality. Exercise doesn't necessarily have to be, running a marathon. It can be going on walks or even swimming. And in just a couple slides, I'm going to show you about some research I've done recently where we actually think that hot water immersion is kind of akin to exercise. And for people who have movement troubles, maybe they have POTS, they get dizzy, that just soaking in hot water can activate mechanisms in your body that may mimic exercise and at least be a segue into better movement. This is a free online cognitive behavioral therapy tool that I always like to plug for my colleagues at the University of Michigan. You should be able to access this here in Ireland. It's called FibroGuide, and it's essentially access to different types of modules that are using cognitive behavioral therapy, psychological behavioral intervention to try and help you live your life better with fibromyalgia by altering how you think about fibromyalgia and chronic pain. So Dave Williams is a good colleague of mine up at the University of Michigan, and they showed that in 118 patients who did this compared to just general usual care, that a lot of them had improved function and decreased pain as a result of just using this intervention. So it's free, it's available, and again, you can access my slides and get the website address from there. These are different types of complementary and alternative medicine techniques. There's not a lot of research out there for these techniques, at least in America. These are kind of not considered voodoo medicine, but a lot of people have trouble accessing them. And in not all parts of our country do we have people who are licensed in acupuncture or qigong or tai chi specialists. But I have had patients do these and say that they can be helpful, and mostly because of the peace and calming nature of these types of treatments. So I'm going to just go forward, but ultimately when we treat fibromyalgia, we want to reduce symptoms of pain and fatigue. And again, that can come from medications, but it can also come from non-pharmacologic therapies. And then I think so importantly is that pain, I mean, I don't know, when you guys see doctors here, do they ask for your pain score? Yes and no. And we care about the pain score a lot in the Americas. Like, we're just like, what's your pain score? What's your pain score? I'm like, well, what's your pain score? That's okay, thanks. But what does that pain score limit you from doing? What pain score would allow you to do those things? Instead of focusing on getting that pain score down to 1 or 2 or 0, maybe it's a 5 or 6, because at a 5 or 6, you're able to have decreased distress, improved functioning. You might be able to exercise more, go out with your loved ones, maybe hit the pub for, or do all the things you might enjoy. A lot of patients with fibromyalgia state that they just don't do the things they like to enjoy because of the pain. It limits them from feeling like they can actively engage in those activities. Okay. Has anybody seen this skit from Saturday Night Live with Eddie Murphy? Okay, I urge you to go online and type in Eddie Murphy Saturday Night Live hot tub. So I was watching one of my friends speak, and she's a basic scientist, and she basically takes little rats and she anesthetizes them, and she puts them in like a little rat hot tub. And I know the story is going somewhere, I promise. And I was watching her give her research, and so she studies metabolism, cardiovascular disease, and impact of certain types of molecules called heat shock proteins on different types of metabolism or cardiovascular outcomes. And I just got to thinking, I'm like, rats in a hot tub. I was like, my patients always tell me they like heat. It's like I never had a fibromyalgia patient tell me like they like sitting in like a giant cold room. But that generally like a hot shower or a nice warm bath or, just using a heating pad makes them feel better. So I got this crazy idea to take humans and put them in a hot tub, like a legitimate medical hot tub. And I got funding for it somehow. I don't know, maybe they just like hot tubs. But I like this because it segues nicely into I am a legit scientist. I did write a grant to put people in hot tubs. So this was, I made this little slide. I was really proud of my graphic design capabilities. I am nowhere near the creativity level of Rachel with this beautiful the logo that you made here. But what we did is we did a baseline visit where we got blood and we did the little quantitative sensory things with the thumb squisher before they had their hot water immersion. So 40.5 Celsius, it's hot. It's hot in the hot tub. We would have them be in the hot tub at chest level for 15 minutes, and then they were at waist level for 15 minutes, and that was 3 times a week for 4 weeks. So that's kind of a lot to ask, someone to take out of their busy life to come participate in research where they're basically getting paid to sit in a hot tub. I thought it was worth it, but patients seem to as well. But then COVID had happened. And then within 5 days of their last heat treatment, we then came and had them repeat all of their tests. And what we found was that after 4 weeks of 3 times a week heat therapy, basically sitting in a hot tub, that our level of pain significantly decreased. And so this is pre-hot tub, post-hot tub, and then the change. So the patients who had the heat treatment went from an average of about 5.5 on their pain score down to about 3.5. Their worst pain ratings went from about a little above an 8 to a 6. And their FIQR, so that's our fancy fibromyalgia questionnaire to assess symptom burden, how it's impacting their lives, that was really statistically significantly decreased. So this is our little p-value on the right side. If it's less than 0.05, that means it's significant. So what we found was that a lot of different measures, their physical functioning and their sleep-related impairment, that's what SRI means at the bottom, that 4 weeks of being in a hot tub 3 times a week was able to reduce a lot of symptoms and pain in patients with fibromyalgia. So shortly after we stopped this, we only were able to recruit 8 people because then COVID hit and no one wanted to sit in the hot tub with a mask. Can you imagine? Just get all sweaty up in there. It's just bad. So when we looked at our basic science data, so we drew their blood, right? So I wasn't just drawing blood to be mean. We actually were measuring levels of heat shock proteins and inflammatory markers in their blood to see, was 4 weeks of heat treatment enough to change how their body was reacting in terms of inflammation? And what we did find was that there was decreased levels of circulating cytokines, which are those inflammatory markers. They had increased exosome production. I don't really know what that is, but it's like a little molecule that transports stuff around. And that we had increased heat shock protein synthesis and production. So do you know what else increases heat shock protein synthesis? Exercise. So what we believe, and again, we're currently just wrote another grant to the U.S. government to try and get funded for doing this on a much larger scale. We're going to need more hot tubs. Is that heat shock proteins are released with exercise. They exert effects on a variety of different pathways, including those inflammatory cytokine productions, and then even opioid receptor signaling. So we found that one of the heat shock proteins is important in activation of opioid pathways. So we are hypothesizing that heat therapy via hot water immersion may mimic the benefits of exercise for fibromyalgia patients, but doesn't require them to get on a bike or go run on a treadmill. Does that mean that I'm saying you should not run on a bike or get on a treadmill? No, not at all. What we found is that patients who did this were feeling so much better that they started doing more activity. So for some of our patients with fibromyalgia who are really sedentary and have a hard time even just going from here to the shower, I had a patient tell me that she hadn't been on a walk with her husband and her dog for over 5 years. And after she did the 4 weeks of heat therapy, she wasn't able to walk far, but she made it down the block and back with her husband and her dog. And she was so grateful and thankful that that type of therapy helped her transition into a more movement-based lifestyle. So we're thinking this might be a good way to get sedentary people to be able to transition to exercise without having that major increase in pain that some patients who start exercising with fibromyalgia have. Okay, so avenues for further research. What do we still want to know? I think there's a lot, and we're going to talk about it today, but it's kind of like, how does your spaghetti noodle impact your treatment outcomes, or what types of treatments work best for you? We don't have a lot of research, at least here in the States, and I'm not sure about here in Ireland. The clinicians might be able to, it's like we just try things and see if they work. And if they do, great. If not, we move on to the next thing. So understanding how that person's, I know I'm being silly, but spaghetti noodle, how you have pain and why you have pain, how does that impact how you your outcomes to treatments? We do know that certain types of people respond well to one drug and certain types of people respond well to other drugs, but we don't really know what noodles work best with what drugs. And then really just the impact of how that multidisciplinary care can be for patients. And then why does including patients as stakeholders make such an important difference? And so I have had a chance to involve my patients in developing some research. And I just wrote a big grant that went in the Friday before I came here, looking at the impact of hormone therapy in transgender patients. What we know is that transgender patients, generally speaking, have higher levels of fibromyalgia, but we don't know how their gender-affirming hormone therapy helps or changes their pain in the long run. And so I actually gathered a group of 7 transgender patients and sat down with them as I was writing my grant. And I've actually asked them to be part of the entire grant from start to finish. And they actually came up with a lot of good ideas, and I summarized them here. So why is it important for patients to be a part of this process? And I think it's, the science is important. Like I said, I mean, I can draw blood, I can measure all of these things, but it's really recognizing the aspects outside of the science that's so important. Because, when I see you in my clinic, I have like 15 to 20 minutes, but I'm not with that person for all those other hours that go on between that visit and the next. Understanding how what we do as scientists may impact those times between, what's important to patients, what aspects of your care are most important. I think that's why we've got these things up here, to understand what about your experience of pain and your experience of fibromyalgia is most needing impact. Is it really the pain score, or is it other things? So I think including patients in this dialogue is important, because we have a chance to hear what this disease, how this impacts you, and what type of research would be helpful in that regard. I think as far as it goes with the transgender community, I've learned a lot about how we maintain. There's some good news happening. How do we maintain safe interaction environments for patients? When I've done my fibromyalgia studies, I've become more mindful about having restrooms or decreasing lights, because some people are photosensitive, or making sure that we inhibit lots of loud noises by having, quiet rooms. So I think understanding how a research experience makes you feel more comfortable is important as well. And then ensuring that data gets communicated in a way that doesn't further any health disparities for a certain group. So I'm sure when research gets published on fibromyalgia patients, that you want that communicated in a way that helps your community, that makes sure that all of the misperceptions and myths that go along with having fibromyalgia, that those aren't furthered by the way that doctors and researchers communicate the findings, right? That's important because it impacts your life. These findings are important because they can change policy and how medications are developed. So we need your voices. We need to know what ticks, what makes you tick, what makes the fibromyalgia bad, how it impacts your life, not just physically, but mentally, because that'll help guide research. So there is hope. Find a physician who can appropriately diagnose and provide referrals and treatment options. As I said, that positive attitude and having those support networks are so important. And kudos to the people who are here to support their fibromyalgia friends or patients, because that type of social connection and support and being visible and validated is so important to patients with fibromyalgia. And then keep motivated and keep trying to get better. This is my Dutch. Tomorrow starts Pride Month. This is my Dutch. He passed away on my birthday this year, so I just had to include him. But I mean, does he not look fabulous in his tutu? So happy Pride Month starting tomorrow, and rest in peace, Dutch dog.